May I then introduce our second speaker, Ms. Tanya Seshadri. Tanya is a medical doctor by training, but is now a faculty member of the Institute of Public Health here in Bangalore. As a medical doctor, she has been involved in clinical work at community level, at district level, and I think that's always very interesting to have people involved in public health that have had at some stage in their career experience with providing care at the community level. So Tanya is going to give a presentation on RSBY, a program that has been mentioned repeatedly already this morning. And she's going to give some concrete figures on some of the challenges and the implementation difficulties that RSBY faces at the level of the district. Tanya, please, the floor is yours. You have about 10 minutes.
Thank you, Bart. Good afternoon, everyone. Like Bart said, I'm going to talk about the impact of Rashtriya Swasthya Bima Yojana, or RSBY in short, on the enrolled households. And I'm going to share with you the experiences from one of the well-performing states in RSBY, which is Gujarat. From morning, we have been hearing RSBY mentioned repeatedly in this debate of UHC. Some people saying we should push it forward, upscale it, maybe we should take it, expand the services provided under it, or expand the coverage, population covered under it, while others saying maybe we should look away from such insurance modules. But no matter what is said, RSBY is a hot topic for debate and has become very popular both in the political circles as well as in, I think, these public health circles where universal health coverage is talked about. I think in the morning, the speakers gave a very clear picture to everyone about the status of health expenditure that Indians face today. A large part of the health expenditure is from private out-of-pockets. Almost 70% is from private spending, and almost 66% is from out-of-pocket. And a large part of the expenditure, almost 71%, is on outpatient care. And that is the main reason for catastrophic health expenditure that the Indian households face. I'll just tell you in brief about the current status of Rashtriya Swasthya Bima Yojana. RSBY was launched in 2008 by the Ministry of Labour and Employment. Currently, the below poverty line households, around 32.4 million families are being covered by RSBY, an estimated 161 million. And I mean estimated because one RSBY household is expected to have 5 members. The assumption exists. And around 4.1 million hospitalizations or claims have been registered since 2008. RSBY in Gujarat was also launched in 2008, and currently the enrollment rate is 50.7% as of last year, 2012. The rate in 2011 was 60%, and there has been a decrease. But Gujarat is also acclaimed to be one of the best performing, well-performing states in RSBY by the Central Ministry. The study I'm talking about is the study of Rashtriya Swasthya Bima Yojana in India. It was conducted in partnership with the Institute of Tropical Medicine, Antwerp, and the Indian Institute of Public Health, Gandhinagar. It has been financially and technically supported by the Alliance for Health Policy and Systems Research and was conducted last year. The main objectives of this study were to study the impact of RSBY in Patan district of Gujarat state in terms of course, the enrollments, access to quality hospital care, and financial protection. These are the 3 aims or the 3 questions that RSBY aims to answer. So we wanted to look at how it was doing with respect to that, and also to list and understand the issues with governance, enrollment, and implementation of the scheme overall. It was a cross-sectional design, and we conducted the study in Patan district, where again the scheme has been in function since 2008. It has been 4 years. The current enrollment rate in Patan is about 45%. And again, in Patan, just like in Gujarat, there has been a decreasing trend in the enrollment rate despite the duration of the scheme. The household survey was conducted in about 3,000 households, and we also conducted some group discussions to try and understand the answers we got in the survey, and of course some interviews among the various actors. Well, I think everyone has been giving disclaimers, so I'm also going to give you one. This presentation is not going to give you any answers to whether RSBY works or doesn't work, but what I hope is I'll give you a picture of what is the exact situation out there, and I think a lot of questions are going to come up, and this will help you understand why people are either rooting for it or saying it needs modification or against it, why it's not easy to be black and white about it. I'm going to present the findings considering the 3 dimensions that were mentioned earlier as well from the World Health Report: the population that is to be covered, the services that are to be covered, and the financial protection that is to be offered. Starting with the population to be covered. Now, as per the RSBY state figures, in Gujarat, in Patan district, about 44% of the population is eligible. So this means that if RSBY were to be provided to everyone, 44% of the population, nearly half of the population, would have access to inpatient services. But as per the figures, 23% of the population, that means half of the population has been covered. In our study, we found out of 2,900, nearly 3,000 households, 95% of the households did receive a card. So when they were enrolled, they did receive a card. But when we actually went to a household and said, now, having the card, does this mean all the members of the household are insured? We found, shockingly, that 34% were not insured. This was despite the household having a card. Because the assumption in the ministry or in the government is always that if a household has a card, this means they have access to cashless health services. But we found 30% of the population is still not included, even though they have a card. This, we have termed it intra-household exclusion, and this is something I will talk about. Within the enrolled households, we found that a higher prevalence of women were not insured, despite the household having a card. And it was a very surprising finding that 76% of the children under 5 were not covered as well. The 3 main reasons we were able to discover from the community for this was, 1, the list that was used for enrolling the households was a 10-year-old list, was done in 2002. And so many of the children under 5, their names being on the list, the chances were very less. Since this list was not updated. Second, because in Gujarat, in Patan as in Gujarat, the average household size is about 5 members per household. And RSBY says that 1 card, only 5 people can be insured through 1 card. And therefore, even if RSBY were to reach all the households, there would still be a significant population in Gujarat households who would not be able to come. So in a household, when they faced this decision, they would put the names of the elderly, their parents, parents-in-law, put the name of the earning members, the young adults, and leave out the children with the assumption that the expenses would be minimal. The third important reason we found was also because the Gujarat government has many welfare schemes for children, mother and under 5s. And so this gave a belief to the parents that if anything happened to the child, anyway there are welfare schemes. And so this made children less of a priority. One important finding, I think those who have worked with RSBY know about this, is the problem with the list that is used. One of the essential problems with targeting, not only in this scheme, but in any welfare scheme. The list used is one that was generated in 2002 by the Rural Development and Panchayat Raj Ministry, and that list has not been updated very well. Every year in the enrollment, there is opportunity for RSBY to update this list. However, this process is not being done, because of which, even when we went for our study, we could not use the list to identify households. And invariably, we had to rely on just going to all the houses and asking, do you know about RSBY? Have you been enrolled in RSBY? Also, the enrollment is repeated every year. I'm sorry. Yeah. So also the enrollment is repeated every year. There is no renewal process. And therefore, 3 months of every year go away in just enrolling people. And people who have no benefits in the previous year are less likely to get enrolled again because they have to pay 30 rupees. So this 30 rupees token charge to us seems almost like a user fees. Because households see it as, I paid 30 rupees for the last 3 years and I have not received any benefit from it, so I should not go ahead for it either. Regarding who is insured, We found a significant increase in hospitalizations among the insured. It was 2.2%, while in the non-insured group it was around 1.5%. While there was limited awareness of scheme, actual details of how to use the scheme, how not to use the scheme. The increase in hospitalizations can be interpreted as maybe increase in access to health services, but also as maybe insured patients are more likely to be hospitalized than the others. 2/3 of the insured users also underwent surgical treatment, which was 3 times higher than the other groups. And therefore, the top 3 diagnoses were hysterectomy, cataract surgery, and deliveries. But one of the reasons we found for this was an apparent decrease in the use of medical packages, because surgical packages are fixed rates. If you say hysterectomy, that's 12,000 rupees the doctor is, or the hospital is paid. No questions are asked. But if you say a fever and admit a patient for 5 days, you have to explain how much bed charges, how many times was diet given, food given to them, what were the drugs given, what were the tests given. And doctors, therefore, have a lot of problems in reimbursing them. You have doctors with no experience in health insurance, with professional insurance companies asking them every single question. And therefore, doctors were stopping to provide medical treatment under RSBY. Regarding the financial protection, we found that only 15% had a complete cashless experience, and this meant that 85% of the users had some out-of-pocket expenditure. When you looked at the median out-of-pocket expenditure, there was no difference between the insured and the non-insured, or the insured but those who did not use the card. And even when you look at the top 3 diagnoses, majority of them had median out-of-pocket expenditure almost as high as 100% of the actual rate. So a hysterectomy, 11,000 rupees. The hospital gets it from the government, but also takes another 11,000 from the patient. And again, one of the most important reasons that the service providers explained for this was the fact that insurance companies created so much problems with the claims, and the chances that the claims would get reimbursed were so less that they felt that their costs needed to be compensated, and therefore they would ask from the patients. So in conclusion, I just wanted to point out that well, we can talk about the problems with implementation of the scheme, like I've already done. We can talk about problems with design, which has been mentioned earlier. This focus on inpatient hospitalizations, which is not the main cause for catastrophic health expenditure in India. But the most important problems are that of transparency and accountability at every level, right from the grassroots way up to the level of the state government, the insurance company. There is a lack of regulation, both at the level of the service providers and the insurance companies. But I think the most important question is, before we start, again, putting in a lot of resources into answering this, where does RSBY stand in the context of the existing health system? I think today morning someone put it very well, that NRHM comes in and encourages decentralization, community participation, flexible financing. RSBY, there is no role for the community. It is completely centralized, and it is the state nodal agency that runs all the orders. At the grassroots level, there's no oversight and no community participation at all. So it's very different the way they are. Now, how do we bring them together? Thank you.
Thank you very much, Tanya, for this nice presentation. I'm sure it raises a number of questions, and we'll try to address them later in the discussion.